My name is Scott Celinski. I'm a surgical oncologist and hepatobiliary surgeon at Baylor University Medical Center in Dallas. How do we define borderline resectable pancreas cancer, and how do we approach the management of these patients? So borderline resectable is a term that is essentially uniquely used in the setting of pancreas cancer for determining operability. When we talk about operability of pancreas cancer, it's generally based on the mesenteric vasculature that is intimately associated with the pancreas and how the tumor involves this. The main aspects that we look at are going to be the venous vasculature, which involves the portal vein, superior mesenteric vein, and partially the splenic vein. And then looking at the arterial involvement, so the celiac artery and its branches, more specifically, usually looking at the hepatic artery and the superior mesenteric artery and its branches. The concept of borderline resectable arose when pancreas surgery was advancing and going after more complex tumors. Looking at these tumors that are involving the vasculature, there was a much higher risk of margin positive resections, and so that's where this term has come from. When we talk about borderline resectable disease, there is no standard definition. There's multiple groups that have brought out definitions, but basically it comes down to very similar aspects in the vascular involvement. The important issues really are with the vein are going to be whether or not the vein is being touched or compressed by the tumor, and whether or not that can be reconstructed if it needs to be resected. If a patient has vein abutment on the imaging, there certainly is a possibility that it is involved and may need to be resected. For the arterial involvement, we generally talk about the superior mesenteric artery, and if there's less than 180 degrees of abutment of the tumor around the SMA, that would be considered borderline resectable. On the arterial side, if there's a short segment involvement of the hepatic artery that can be reconstructed, that generally pushes us into the borderline category. In addition to anatomic borderline resectable disease, there's also some other classifications of borderline resectable. So the first one that we already talked about is anatomic considerations. The second two are more patient considerations. We can look at poor functional status. So it's not that the tumor of the patient is borderline resectable, but the patient is borderline resectable in as they may not survive an operation just based on their functional status, which potentially we can improve that and get them to resectable. And then there's biologic borderline resectable. So many of these patients will have small pulmonary nodules that are indeterminate, kind of wondering whether or not this is metastasis or benign nodules. And so that may push them into this biologic borderline resectable category. When it comes to management of borderline resectable pancreas cancer, the general consensus for the management of any classification, whether it's anatomic, functional status, or biologic, is neoadjuvant therapy. For the anatomic borderline resectable, we're trying to increase the likelihood of a margin negative resection and get them to a resection. For the patients with poor functional status, we're hoping that their functional status improves during therapy, which when the cancer is what's causing their decline, response to therapy can significantly improve their functional status. And then in the biologic borderline resectable, we're taking these patients who have potential metastases and getting a biologic test with time. Do these metastases bloom and show us that these patients are not candidates for resection? Generally, we focus on the borderline resectables for getting to surgery. One of the key things for increasing the likelihood of a margin negative resection and improved outcomes is normalization of the CA19-9 during their neoadjuvant therapy. When we're looking at response to therapy, radiographically, we oftentimes don't see a change in the tumor. But pathologically, many of these patients will have significant pathologic response or even complete pathologic response. So what we're really looking for is not necessarily a shrinkage of the tumor on therapy, but rather lack of progression to consider offering these patients an exploration and potential resection.